on this act? What's going on? This doesn't sound like it's normal. And certainly can check your chart to see in any of those areas where that can be done. For children, in cardiac catheterization, when there is, and adults will usually think of them having cardiac catheterization because they have coronary artery disease. And the cardiologist wants to get an idea of what vessels are plugging off, or what is the pressure readings within the heart itself, which shows them some other things that may be occurring. So it's not really any different. Normal chamber pressures, we don't need it for pediatrics. Med-Surg 2 might be questioned about it. But just knowing that you're going to have less pressure, certainly sitting here on the right side, so it's less muscular, and it's going into the lungs, which are low pressure, through blood flow now, hemodynamics, than what's on the left side, which should be higher pressure, so there's more muscle there, more push there, so that blood can get out to the body itself, systemic circulation. So they go ahead and they will go in and introduce a catheter. On adults, they will put it into can be femoral, can be subclavian. Their more favorite ones now for adults is to go into the radial artery. But however and wherever they go in, they are entering a vessel. And this vessel is going to bleed seriously after it has been punctured and a thin catheter fed into the vessel so that it can get to the inside of the heart and figure out what is going on. The nursing responsibilities are going to start with preparing child and parent for this procedure. Certainly if the child has already been diagnosed with a problem, there's the emergency surgery center. They're going to be coming back again and again and again for cardiac catheterization to see how are things going on. So, getting it in there, shooting a substance into the heart itself so they can see how the walls are working, how the coronary arteries function, etc. When they go ahead and shoot this fluid in, it gives the person a very warm feeling. Adults will speak to it when it goes in, so we warn them ahead of time. But what are we going to do with children? They are not unconscious. They are sedated, so they don't really want to move, they're crawling around, etc. But this is something that has to be told to individuals. They're going to be in a room. It may be somewhat dark. There'll be people talking. There's going to be and they may feel sensation. Now, for adults, their NPO for 8 hours, 12 hours, whenever they want to get them down there, etc. Kids, we only keep them NPO for about 2 hours. Infants, they can't do much longer than that. Going to have IV fluid going on. How they sedate them is going to vary. Children, we usually try to give them something to drink, but you can't. They're going to have an IV, and they can just drip something in which will make them quiet. Not unconscious, just quiet. When they do the procedure, see what's going on. And then they're going to remove that catheter. If it's just for a checkoff, if it's something else that's going on, they'll take the catheter, one of the parts of the catheter, and send them to ICU. But what needs to be done is now the nurse's responsibility. Certainly, vital signs. Remember, they've entered an artery. If they're looking at the right side of the heart, they've entered an artery. If they're looking at the left side of the heart, wait, what did I just say? They're looking at the right side of the heart, they've gone through a vein. They're going to look at the left side of the heart, they're going to enter an artery. So stop and think about how blood is following, what blood is coming out of it, just backtracking it. Vital signs, very important. Certainly we've got vital signs before they wet, They're taking vital signs constantly while they're there, and you need to watch vital signs too. What could possibly go wrong post-procedure? Blood pressure can change. Why would blood pressure change? Vein, we don't worry about pressure in the vein. Why was that perforation? That artery could have been nicked. They could be bleeding internally. So we're looking at vital signs all the time. There's going to be a dressing over the area. They still use pressure dressings. There's now more other things that put a little bit of glue to the vessel. There's various ways to try and seal off that vessel because there's been a significant hole placed in it. And if it's just pressure, you're going to be standing there for a long time holding that one. And then they seal the pressure dressing. We're looking at dressing. If they enter the femoral area, say in an older child, even a younger one, and there is not stasis of that possible bleeding, a lot of bleeding can take place back into the groin, and you won't be able to see. It doesn't pour out all over the floor. It's going to leak backwards. So the only way you're going to know is there a leak? Vital signs. Certainly if the blood is no longer in the vessel, that's going to change things going on. And using your fingers and palpating the area. Because the areas still should be soft. If they start to feel kind of hard or rigid, why is that? Well, the heck of a hematoma is developing. Make sense? So, vital signs, dressings, we want to be sure they're taking fluid. They generally will have an IV. Looking at glucose levels, if it's an infant, they're just blazed through a lot of calories. So you've got to make sure they know the glucose level that is functional for them. And if it happens to have been in the lower extremity, or even upper extremity they're using, you always want to take the pulse distal to the insertion site. Which means what? Away from that area. The further away it is. So you've already checked the pulse. How did they feel? Particularly lower. Could you get a dorsalis pedis or a post-tibial? You're going to go back and check again and again and again. To make sure those pulses are basically still about the same as they were prior to the procedure. That's usually a question on every test we ever get around here. Okay, yeah, well, some people are. Okay, so fluid intake, watching them for hypoglycemia. How would an infant indicate that they're hypoglycemic? Okay, who here have kids? And how do your kids act when they're hungry? I know when they're big and tall, they can just raise the refrigerator and get a little bit. Got a little irritability. What else?
My mom verbalized. I'm hungry.
Your kids are too old. Okay, give me somebody small. Yeah. Are they playful?
No.
Are they a little, let me use the word, listless?
Yeah.
Oh, okay. So we are watching for all of those signs as to what's going on and identifying the changes that may be taking place in those chemistries and their vitals. And then positioning. You want to position where there's not going to be any obstruction of blood flow. 5-year-old, etc. You don't get them up to sleep. They're going to have to lay quietly for a number of hours. We want to be sure that that site, that venipuncture site, has definitely sealed over and there's not going to be any bleeding. So we want to carefully, just lie there quietly, lie on your back, or on your side, but that site must always be visible to you. Any questions so far? Yes.
Just to verify, you said that the baby method work?
The page method will start closing. It should close before the end of the month, for sure, right? It closes by the Soviet, which means it's 28 days. But we like to have it, and that's what we like. We always tell families, bring the child back after birth within a week, 2 weeks, so we can have checked and see how things are. If it's still loud, it's boring, when he hears, it starts to close, and how's the child feeding? So it gives you indication that it's compromising the development of the child, growth of the child. Question?
No.
Stretching already?
No.
Okay. Okay, now into, and this is where you went. Okay, congenital heart defects. You're all down in Texas children, so if there's any place to see congenital heart defects, that's certainly one of those things going on. And you can see 2 or 3 of them. The number of 2017. So 1 out of every 120 babies, parents, et cetera, they have heart defects going on. But only 2 or 3 of these are symptomatic in the first year of life. So the first year, they can look pretty good. Certainly you have those that will bring their child in every time your child sneezes, so you're constantly listening to them and looking at them. And then there's those that have no problem with the children, so why are they taking them except for their immunization, except and a few other minor things going on. So they can, first year of life, they may never show that they have a congenital problem. They may not be the fastest grower in town, but they are growing and there's some thriving going on, but they're not as bouncy and about as they could be or should be. Major cause of death, first year, yes. The maturity takes a larger group, and then after that it's the heart that will end the child's life. One common one is ventricular septal defect. That's the hole between the ventricles. Think how messy that is. The left side of the heart has the greater strength. So basically, every time the left side of the heart contracts, it's shooting oxygenated blood over to the right side. Blood's going back over there, that means it's not getting out to the body, and it's being sent back to the lungs again and again. Remember, the lungs are low pressure. They don't like to overwork. There's circulation. And then some of the other things that can cause the congenital heart defect, the trisomy collection itself, which is responsible for Down syndrome. Down syndrome comes in multiple numbers, different things that are changed. So after that, it starts becoming other syndromes that are possible. Okay, let's look at some structures. Malformations, left to right shunt. Might as well get used to these shunts because I guarantee they're going to be on the test. Left to right shunt, which a shunt is where how a fluid will move in a direction. So if we have a shunt left to right, we're talking about blood, being the fluid moving from the left side to the right side of the heart. No. This is going to cause all kinds of hemodynamic problems itself. It will increase pulmonary flow. So the lungs are once again getting additional blood in there. What happens in the lungs, which is a low pressure vascular site, is it's going to fail. The vessels cannot handle that, and hypertension develops. Pulmonary hypertension. Pulmonary hypertension is fatal. There are the malformations that will cause a right to left shunt, which means now blood really isn't getting to the lungs. So these children are not exactly going to be pink. Make sense? And then those malformations that just won't let blood through itself, which creates quite a number of problems. So, these are structural problems. Congestive heart failure, which you're going to get in med surg, as you're saying, you're talking about congestion in the vascular system due to the fact that the heart is failed at the pump. Adults, and for children, congestive heart failure is due to structural problems. That is not what it is in an adult. Congestive heart failure in adults is not structural. It's due to the pump wearing out. So, but there is still that left and right side failure that will occur. Either the right side just gives up or the left side gives up. And in children, muscles will become even more damaged if not treated. So, what do we see in congestive heart failure in children? Which is not exactly not what we see in adults along the way. So, infants, they will turn blue during any exertion. So they're not playful kids. They can't be. They just can't get enough blood circulating because this heart has failed as a pump itself. So dyspnea, problem. Why would it be dyspnea? Either there's too much blood backing up into the lungs, which is going to make it very difficult for oxygenation to take place and blood to get out. Fatigue, yeah, their heart's tired. They're not doing it. Failure to thrive, and that's many times what brings it. This child is not meeting goals. If you look at a percentile and all, they're just not there at all. Okay, hypotonia, they're kind of floppy. They don't have that same muscle response. You pick them up. You pick up a baby and it kind of curls in your arms. If you pick up this, you might as well be picking up a raggedy man. They just don't even have the strength to have muscle tone. Okay, excessive sweating. Babies do not sweat. So look at the stress this body is under when you got a baby that is sweating. And then single cells. Well, infants can't tell you so much, but they look like they want to faint. You know, their eyes kind of roll back, and they just, come on, baby, come on. And anoxic cells, they just don't have any, it's not hypoxic, it's anoxic. They just stop breathing for a little while. It's too much energy to breathe, so they just kind of stop breathing on you. And remember, I did say babies, infants are far more prevalently going to have a respiratory arrest than a cardiac arrest. Okay, older kids, as time goes on, they're slowing growth, delicate, frail. They can't, what's going on? I'm going to talk specifically about squatting for relief. Older kids can go and squat for the one congenital one. We have to squat the child. We kind of fold them up. So it helps with blood return to the heart. Headaches, epistaxis, nosebleeds. We see in these children that are going into congestive heart failure. And you say, well, why would they have nosebleeds? If blood is not moving through the heart effectively and efficiently into the arterial circulation, it's going to be backed up in the venous side. Does the venous side like a lot of pressure on it? Wherever there's delicate blood vessels, they may rupture. So we see these children having nosebleeds. Make sense? Leg fatigue. Yeah, it takes a lot of energy to walk around and do things. The muscles just don't have it, so they don't. So when looking at it, I think I gave this to you all, what one sees as a normal thing that happens with congestive heart failure. I gave you this slide. Okay, so you have it there. So you might want to review it. Okay, what is the treatment? Well, the heart is failing, so the treatment is make the heart work better. And how do you make the heart work better? Okay, let's start with the Digoxin, everyone's absolute favorite, one of the digitalis glycosides itself. And they are, how does digitalis, Digoxin work? What does this affect on the heart? What does it do that makes it a stronger pump? This is a benchmark drug. You will be tested on this ad nauseum, even more. You can't get over it. So you want to know about this. So what does it do? How does it increase cardiac output? Now you look at that, which I appreciate. But how does it increase cardiac output? Okay, there's an improvement contractility. It does not work on the muscle, so don't get it mixed with that. What is the primary nursing activity you do when you are giving dig? You check for the pulse, because it slows down the pulse. It slows down the conduction from the atrium down to the ventricle. If it slows down the pulse, that allows for more time for filling. All right? And going back to something in physics, which I try to forget as frequently as possible. Better stretch, better contractility. It's like a rubber band. The more on a good rubber, the more you stretch it and let go, the further back it'll go and hit somebody else. If you have a rubber band that's just worn out, and you give no stretch to it, it's not going anywhere. All right? So that's going to increase cardiac output. How much blood is now going to be pushed out because the heart rate has been slowed down to allow for better filling. Decrease cardiac size. Yeah, it will. Not by itself, but the fact that the heart's getting a better fighting chance. Because if it doesn't, it becomes a real floppy heart. The muscles just get stretched, and they're like the rubber band that gets stretched too much. So venous pressure decreases, all of those wonderful things, just because you get a better heart beat, or a better heart action. Okay, your ACE inhibitor. All right, who is it that I've had a renal clinic? All right, what's the kidney does for a living? ACE inhibitors, angiotensin converting enzyme. Angiotensin is converted. It is that which will increase your blood pressure, which is the last thing they need. So when they give them an ACE inhibitor, it relaxes the blood vessels, making it easier for that left side of the heart to push blood out into the system. Okay, your beta blockers. I'm sure Dr. Daniels went through that with a fine-tooth comb. Same thing, decrease the heart rate, etc., but other problems can occur. Okay, getting rid of accumulated fluids. How do you get rid of accumulated fluids?
Diuretic.
You get rid of diuretics. You watch how much fluid they're getting. Also, so intake and output is an automatic. You don't need an order for intake and output. Okay, decrease cardiac demand. The biggest demand the heart has is actually for oxygen. So how are you going to decrease cardiac demand? Give them oxygen. What else? Because the more the heart works, the higher its oxygen consumption. So what else can be done? Raise the bed up? No, they're not having a cardiac problem. Think of what? Decreasing activity. Now, we're not talking about, say, don't move a muscle, but you're going to decrease how hard they have to do something. So you're looking at what is going to make it a little bit easier on this child. If they want a toy, getting up, going over there, getting it, etc., is not the ideal. Placing it a little bit closer where they can pick it up and throw it at you and then tell you what they want, if that. Improve oxygen, tissue oxygenation, yes. A little supplemental oxygen is always good. Make sense? Yes. Okay. So all of those things. So the nurse is here, and I just gave it all to you through that. nutrition, is certainly something, getting those calories on board. Remember, they're too tired to take a